Pediatric Eczema by Jessica Anderson. Atopic eczema is often interchanged with atopic dermatitis and is a common chronic pruritic inflammatory skin disease that is characterized by acute and chronic skin eruptions. Most patients with eczema have a mild to moderate form of the disease, but some develop severe eczema and may present with widespread skin lesions. Atopic dermatitis impairs the skin's ability to act as a protective barrier, which can result in bacterial, viral, and fungal infections. So what is the incidence of eczema? Approximately 10 to 12% of children in the United States are affected by atopic dermatitis. It develops in 85% of children within the first 12 months of life and in 95% of those before the age of 5. It is interesting to find out that asthma and eczema can have a direct correlation. Up to 50% of affected infants develop asthma or other respiratory issues such as allergic rhinitis or hay fever. Although the risk factors for eczema is not always clear, there are many genetic and environmental factors that can influence the development of eczema. Atopic dermatitis is associated with an elevated serum IgE. A high serum IgE level is a strong risk factor for eczema in children from birth until 6 years of age. There has also been found to have a mutation in the filaggrin gene that can cause moderate to severe eczema, and that has been seen in about a third of people of Northern European and Eastern Asian descent. Also, a positive family history of eczema increases the chances of a child also having eczema. So what are the signs and symptoms of eczema? We have acute manifestations as well as chronic ones. The acute are usually seen more common in infants and can include intense itching and redness. You can see papules, vesicles, edema, serous discharge, crusting of the site. There's a generalized dry skin that can include the scalp, but usually the diaper area is spared. Lichenification is typically not part of the acute manifestations, whereas it is in chronic. The chronic manifestations are more common in adolescents and adults. And again, we can see that thick, leathery, hyperpigmented skin. We can see scratch marks that may be present, flaky, rough skin also, as you can see from the picture below. So what are some of the diagnostic studies that we can use? The biggest thing is just a thorough examination and history of our patient, assessing the patient head to toe, looking for those chronic or recurring rashes. Again, there's really no specific test that confirms a diagnosis, but that elevated IgE can help support a diagnosis of eczema. If you look below at the two children, one of these children have scabies while the other one has eczema. So there is things called skin scraping that can be performed to rule out scabies. You can always refer to a dermatologist. The picture on the left is actually eczema. The picture on the right is scabies. So sometimes that can be hard to determine in the pediatric population. You have to think about the psychosocial impacts of eczema. Up in the top, eczema is not contagious. People don't always react very well to rashes. They automatically think that they're going to catch something, that, the person is dirty or something like that. So that can lead to some depression and anxiety in these patients. Sometimes they feel discriminated and isolated in social events or gatherings, which, decreases self-esteem. Some of the physical effects is just that it's very painful, it's uncomfortable. A quote here was like, some patients say it's like having 1,000 paper cuts on the skin. So physically it's uncomfortable, and emotionally it can be draining on the patient. As a provider, we always have to think of complications that can arise. One of those that can happen is eczema herpeticum. And that is a very serious infection that can happen, and it spreads over a wide area of the skin. You can see clusters of blisters that are itchy and painful. Those blisters can look red, purple, or black. They can ooze pus when broken. You can have high fevers, swollen lymph glands, not feeling well overall. Complications is we can have scarring from those blisters, infection in the cornea of the eye, known as herpetic keratitis, which left untreated can lead to blindness. In rare cases, organ failure and death if the virus spreads to the brain, lungs, and liver. I have seen this actually in practice, and it is as bad as it looks on here. The child is miserable. It absolutely is terrible to see in person. Some of the other complications of eczema include staph infections, including impetigo, which is that honey-colored crust that can form on any open areas of the skin. Those boils, which are those red raised bumps that can weep with fluid. Cellulitis, of course, is that deep infection in the skin. It's painful, tender, can cause fever, blisters, and dimpled skin. And the staph scalded skin, which is absolutely horrific to see, is the infection causes that peeling of the skin over large parts of the body. And I've also seen this in practice and trying to start an IV, you have the skin sloughing off. It's just terrible to see as well. The treatment options for eczema include non-pharmacological as well as pharmacological treatments. Dry skin tends to worsen the itching and rash, so making sure to keep the skin well hydrated and lubricated is very important. Moisturizers help keep and maintain that hydration. Those ointment-based emollients such as Vaseline and Aquaphor are good examples that can be applied, especially after getting out of the bathtub. Which leads us to avoiding those really hot baths and avoiding keeping the kids in the bath for long periods of time. It's important to keep the fingernails short. That helps prevent trauma from scratching, and also that scratching can also cause infection. Do not use any of those harsh detergents or soaps. Some of the pharmacological treatments that can be used include antihistamines. Antihistamines aren't the greatest at helping pruritus, but it does help sedate. So itching can be worse at nighttime, so things like Benadryl can be given, helps the kids sleep a little better at night while also controlling the itch. Topical corticosteroids are also some of the pharmacological treatments, as well as those TCIs. But keep in mind the TCI is a second-line therapy. Wet wrap therapy is something that can be used, as well as oral antibiotics and topical antibiotics and antiseptics. So what is our goal as a nurse practitioner? It's to provide education to the patient and the family that this is a recurrent disease. Teaching the family how to control the itch, scratch, itch cycle is very important. Focusing on making sure the families and patients adhere to their treatments and are well educated on medications, caring of the skin, those triggers that can be avoided in the environment, and also teaching and educating on what signs of infection look like. Some of the best resources that I have found included the National Eczema Association as well as American Academy of Dermatology Association. They both had some really good support groups and information on eczema on both of those websites. So for your discussion questions, the first question is a 14-month-old comes in with a flare of his eczema. The patient has these dome-shaped vesicles that have ruptured all over his face, and these lesions are oozing. The remaining blisters appear red, purple, and black and appear to be painful to the patient. And as you can see by the picture, this is what we're looking at. What do you think the patient's diagnosis will be, and what should you do for this patient? The second question is, what are some things that parents can do for their child to prevent the itch, scratch, itch cycle? And number 3, how would you educate a family member who is terrified because they were sitting beside a patient with eczema and now they fear they will get this rash? And here is my references. Thank you for watching this presentation.